Occlusal splints are one of the commonly prescribed conservative treatment for TMD patients. However, not every patient needs a splint, and not every splint is appropriate for every condition. Splints are reversible appliances that should always be prescribed after an accurate diagnosis. The primary goal of splint therapy are to reduce pain, decrease muscle hyperactivity, protect teeth from parafunctional wear, reduce joint loading, improve jaw function, and promote neuromuscular relaxation. They are adjuvant to treatment, not a cure for TMD. So the stabilization splint, which is called as Michigan splint, is most commonly prescribed appliance and is considered the gold standard for patients with myofascial pain, sleep bruxism, muscle tenderness, and clenching habits. It provides even occlusal contacts, reduces muscle activity, protects the dentition, while the anterior bite plane is indicated for short-term management of acute muscle pain and severe clenching also. It should never be used long-term, as prolonged use can result in posterior open bite and permanent occlusal changes. The repositioning splint is reserved for carefully selected cases such as painful disc displacement with reduction or intermittent joint locking. Because prolonged use may alter the occlusion, it requires careful diagnosis and regular follow-up. Splint therapy is indicated in patients with sleep bruxism, persistent myofascial pain, parafunctional habit, muscle tenderness, and selected internal derangements. It is not recommended as a routine treatment for every patient in TMJ pain or joint clicking. We make certain common mistakes like prescribing splints without a definitive diagnosis, assuming every TMJ click requires a splint, using anterior bite planes or repositioning splints for a prolonged period, failing to review and adjust the appliance, and relying on the splint alone while neglecting patients' education, self-care, physiotherapy, and behavioral modification. Current evidence supports stabilization splints for selected patients, particularly those with myogeneous TMD and sleep bruxism. However, the best outcomes are achieved when splint therapy is combined with comprehensive conservative management programs. So, what we learned today is that the success of splint therapy depends not on the appliance itself, but on selecting right splint for the right diagnosis. So, treat the patient, not just the bite.